Welcome to Endo Untangled. I'm Dr Alicia Macro, GP with a special interest in endometriosis and pelvic pain, joined as always by my lovely co-host, accredited exercise physiologist Sheree Noble. This podcast is where we unravel the many threads of endometriosis and pelvic pain, the science, the stories, and the people who are pushing it forward. Today, we're delighted to be building on our last episode with Ali Deslands. In this episode, we're talking to the exceptional Dr Matthew Leonardi, not just about the scan, but what happens after the scan. Dr Leonardi is an Associate Professor of Obstetrics and Gynecology at McMaster University in Hamilton, Canada, and Honorary Adjunct Lecturer at the University of Adelaide. Matthew is recognised internationally for his work in complex endometriosis excision surgery and gynecological ultrasound, and is the Medical Director of Clinic Endometriosis 360. Matthew is a leader in combining imaging, surgical care and multidisciplinary rehabilitation in pelvic pain. Dr Matthew Leonardi, welcome to the podcast.
Thank you, Alicia. Thank you, Sheree, for having me here in Adelaide for this podcast, Endo Untangled.
We are super excited to have you here. And a bit like the night before Christmas, I literally did not sleep last night because I was so excited about having you on. And not only have we had Endo Barbie here, or Research Barbie here, we're following on directly with Endo Ken, or even the Disney Prince.
I'll take either. It is a podcast, so people just have to use their imagination.
I know, that's right, actually.
I think everyone's paused now and they've actually want to watch
Gone
it.
straight to the video.
Gone straight to the video.
Exactly.
Those people that usually just listen, they're now hooked on the screen.
That's right. I've heard you allude to the idea that Endo kind of called you. Can you tell us what you mean by that and how that shaped the kind of surgeon and sonologist you've become? And also if you can tell us a bit about what that means as well.
For sure. When I was doing my residency in Toronto in obstetrics and gynecology, I knew I liked surgery. I knew I liked ultrasound, but finding a combination of the two in a Canadian landscape was not so possible because gynecologists in North America don't do ultrasound. And a lot of gynecologists around the world don't do ultrasound, but in Australia, there's quite a number that do. And so I decided to come to Australia, to Sydney, to do my fellowship and combine the two, ultrasound and surgery. And I didn't really realize that endometriosis was sort of the centerpiece illness, disorder, disease that combined those two domains as much as it did. So when I arrived in Sydney, the clinic that I was practicing in, doing my fellowship in, really focused mostly on chronic pelvic pain and endometriosis. And when I started to learn about endometriosis a lot more in a focused manner versus in a general manner, which you do in your residency, it just really kind of took me over. It became this enigmatic puzzle that I really found fascinating and wanted to start to solve the puzzles. And I had a great opportunity from Prof Condis because there was an academic, a research infrastructure in the unit. And so lots of studies were happening. And the more I started to do some of the research, the more intrigued I got. And then it fully took me over. And that became the primary disease of my whole practice and of my research program at McMaster University. And I'm happy that that's happened because it's such an important disease to talk about. It's such an important disease to help solve those puzzles because millions of women and individuals who have endometriosis are struggling.
Absolutely. And it's such a complex area. We keep coming back to this in this podcast, how complex pelvic pain is. But I imagine as a surgeon, you bring such a unique aspect and lens to your ultrasound as well, because you'd have to be good at thinking about things in 3D and sort of building a picture up about what's happening in your mind. And it must be able to, inform your work so much. Can you tell us a bit about, how your own ultrasound, your own high quality ultrasound might inform your work as a gynecologist?
It's really fascinating to have that surgical foundation and then add on to it the imaging, because as a surgeon, you see things mostly in 2 dimensions. I mean, open surgery is 3-dimensional, but laparoscopy, which is mostly how we do endometriosis surgery, is on a screen. It's 2-dimensional. And you have to envision the 3-dimensional anatomy, the pelvic retroperitoneal structures. And when you enhance that surgical view with the ultrasound view, whereby you can see through structures, you really create this amazing synergistic view in your head. So when I operate, I literally see the screen, but I'm envisioning through the structures thanks to my knowledge in ultrasound. And when I'm scanning, I'm also envisioning the surgical planes, the surgical anatomy, the pathology. And those two things really enhance each other more than either of them could individually.
Because there's so much, like we were talking with Ali last week around how ultrasound used to be about, let's have a bit of a look at the uterus, let's have a look at the ovaries, and that was about it. But that's not what this looks like anymore for endometriosis surgery.
Absolutely. The ultrasound can see so much more than what we thought. It's even going beyond the borders of endometriosis now into looking at the vessels of the retroperitoneum, looking at lymph nodes in the retroperitoneum. We're trying to understand the muscles of the pelvic floor. So ultrasound's potential is really insane. It's just we haven't really considered it yet. But as it pertains to endometriosis, we can see so much more than the endometrioma in the ovary. And that's really pivotal for that surgical decision-making and clinical decision-making. And so I'm hoping that more and more people around the world are going to be shifting from this quite rudimentary ultrasound of looking at the uterus, looking at the ovaries, to looking at the pelvis entirely.
You just mentioned endometrioma. So I think that's probably a good segue to kind of discuss this a little bit further because, what is it? Actually, because we often hear it described as a cyst or a chocolate cyst, but, what is it and, what's happening structurally there?
An endometrioma is an ovary that contains blood that's from endometrial-like tissue within the ovary. Essentially, when an endometrioma forms, it forms usually at the site of the peritoneum, which is the lining of the abdominal cavity, and the ovary sort of invaginates around it or envelops the endometriosis tissue. And through the stimulation of the endometrial tissue with hormones, there's a bit of a proliferation and a shedding, much like the endometrium itself within the uterus. And over time, that endometrioma can grow thanks to the fluid buildup. But the fluid can't escape the ovary because it's stuck to the peritoneum, it's stuck to a nodule of some kind. And so they can get quite large. I have a patient right now who's got an endometrioma up to 20 centimeters.
Wow.
So they can fill the entire abdomen. Fortunately, most don't get that big, but they can. And having the knowledge of the endometrioma size, the appearance, the location of fixation, where it's adherent, is all really key to that surgical planning if surgery is going to be done.
So it's not really like even it's a cyst at all? Would you think that really?
It's actually not a cyst.
Yeah.
So it's not like a dermoid cyst or a serous cystadenoma, as many people call a simple cyst, follicular cyst type. It's not in the ovary, although it looks like it is because the ovary kind of wraps around it rather than it being truly within. Although there is a one type of endometrioma that's probably the more rare type. It's the origin, probably a metaplastic origin, where there's cells that are within the ovary that somehow change to an endometrial cell. And then those do contain endometrial tissue. And those don't usually get stuck to something because it's a different way that they form. But the primary mechanism by which endometriomas form is this invagination around endometriosis tissue. So it's not a true cyst.
And how does it show up for a patient? And is it fairly common?
Endometriomas are the most common visual cue for endometriosis, though not the most common subtype of endometriosis. The most common subtype is superficial endometriosis. But endometriomas are often what we think of as the tip of the iceberg because they're the easiest thing to find, even on these basic ultrasounds that we've been chatting about. When people view the ovaries, they can see them. But if you don't look for the other forms of endo, you don't see them. So it's sort of the tip of the iceberg. Many patients will present usually with symptoms of pelvic pain, usually cyclical period pain, and they may have pain outside their cycles. And some people will find out about their endometriomas when they are experiencing infertility. And their first gynecologic scan may be with a fertility clinic, and they detect an endometrioma. But unfortunately, a lot of places around the world are still not really using the proper terminology. So they're describing these as complex cysts. We'll see that on a lot of reports. That doesn't tell anybody what it is. It just tells us that it's not something simple or sort of fluid filled with just follicular fluid. And even now, we're starting to see a transition to some terminology around the world called the ORADS terminology. It's the ovarian nomenclature amongst radiologists. And they often will say ORADS 2 or ORADS 3, but not actually say that it's an endometrioma. And I really want to help people realize that it's good to characterize something, is it worrisome or not? Is it simple or not? But let's just call it what it is. When it's an endometrioma, we can be quite confident just based on the sonographic ultrasound patterns.
So I guess if we were thinking through what the different kinds of cysts are, perhaps we should just go through that in a little bit more detail. So, one of the difficulties is the terminology. And so for someone who's got polycystic ovarian syndrome, they might be told that they've got lots of cysts, but they don't. That's actually not really cysts, is it? That's developing eggs.
Correct. Those are follicles.
They're follicles. So they're actually not really cysts at all.
No.
Sorry.
The challenge with individuals with PCOM morphology or PCOS, if they meet the other criteria for the syndrome, is that they do often form follicular cysts because they often don't ovulate. So they have what are called anovulatory follicular cysts. And so if they present to their doctor and they get a scan, or they present to the emergency department with a pelvic pain episode, you may actually capture one of these follicular cysts. That's an anovulatory cyst, meaning a follicle that doesn't actually ovulate.
Okay.
And so then they do have a cyst.
Yes.
In the context of an ovary which has a lot of follicles.
Yeah, right. Okay. And they can be quite big. And I imagine if they are that sort of cyst, they're going to be pretty simple looking, meaning that they're just like a bubble with fluid in it, like a big blister, and that you can probably see that on an ultrasound.
Correct. It's black on ultrasound, meaning it's clear in real life, meaning it's just some follicular fluid that will usually either spontaneously resolve or they could actually rupture. And that can be a cause of an acute pelvic pain episode for a person, but it's a time-limited event.
So it happens and then it gets better over perhaps hours or days.
Yeah, and maybe it'll form again, which is relevant, when we talk about the holistic view of these patients. We want to be really nuanced in what are the pain generators. And so, one of the theories that our team is currently working on is that there's actually an overlap in people with PCOS and superficial endometriosis. And we often will focus a little bit more in on the superficial endometriosis, the pain generator, but maybe these people are having regular anovulatory bleeds, which have been in the literature shown to be more painful than an ovulatory bleed. And also the regular formation of these anovulatory follicular cysts, which can then rupture, become haemorrhagic in some cases, meaning blood-filled, that's also painful.
Yes.
So what's driving the pain in this person who's been told they have endo? Is it the endo, or is it this sort of ovarian event that's happening repetitively? And if you only focus in on the endo, you're going to fail to manage the patient from a more holistic perspective.
That's so interesting. So, and the way I think about it and the way I explain it to my patients is that if a cyst like that ruptures, it's probably got fluid in it, and sometimes there'll be some blood as well. And that blood will end up in the peritoneum, which is that kind of plastic glad wrap bag that everything in our pelvis is sort of sitting in, or the majority of what's in the pelvis is sitting in. And that reacts to that. It doesn't like the blood, it doesn't like the fluid, and that sets off an inflammatory process, which can be really painful. And so I don't want to get too far off track here, but I often find in women with endometriosis and persistent pelvic pain, they may have a significant pain event from just a normal ovulation, for example, or if they did have a cyst burst, they get perhaps just perhaps it's a half a mil or a mil worth of fluid, maybe a little bit of blood in their pelvic cavity, and bang, whoomph, and we've talked about that fired up nervous system in the past. And I'm probably going off on a tangent here, which I shouldn't be, but lovely to kind of, think through that. And particularly, if there are women who are having these recurrent, bigger cysts rupturing, sometimes the opposite is true. Sometimes I've heard you talk about this on podcasts before yourself around sometimes those cysts get blamed for things that someone else did. So, it's kind of like the kid at school who keeps on getting in trouble, even if there's a bunch of other kids who are being naughty at the same time.
Mm-hmm.
Yeah, they're the pain generator.
Oh, for the teacher.
For the teacher. But it does remind me of our, we talk a lot about zooming in and zooming out is one of our philosophies. And we talk about zooming in on the pelvis, but then zooming out sort of more holistically. But what's coming to my mind is also in the context of the pelvis, you can even zoom in and zoom out there.
Mhm.
So sometimes we're zooming way too in on one thing given the context of the pelvic area. And it sounds like the way that you approach this is collecting all of the information with the technology and the resources and the clinical expertise that you have to then also zoom out within the context of the pelvis to take in all of the information. And how important that is that as a medical practitioner, surgeon, all health practitioners to be able to open that lens?
It becomes really easy to focus in on endometriosis as the scapegoat of all the problems. And as amazing as it is for endometriosis to be receiving as much media attention and attention in health systems, especially in places like Australia, we do need to zoom out, because if we just focus on the lesions, we're actually missing a lot of the main issues that these people are facing. And if we then only think about, let's remove the lesions, these people are going to be unhappy with the result of that. And they may pursue multiple laparoscopies hoping for something different to happen. If we zoom out and we understand the patient as a whole, and in particular, the pain system, as you've highlighted. And I love the term that was coined by Lorimer Moseley out of Adelaide, pain system hypersensitivity, that peritoneum highly sensitized to an event that's not actually dangerous, to an event that's somewhat, there's a little bit of a pathology to PCOS and the formation of these follicular cysts, but it's somewhat tied to physiology. And these events are not meant to be dangerous, but the body perceives them to be. So we do have to zoom out and try and take that global look. And I use the ultrasound tremendously to do that. So it's not just about endo, it's about adenomyosis, it's about the ovaries besides endometriomas, PCOS or PCOM, as we should be calling it on ultrasound, other types of ovarian cysts, things like fibroids, although also not traditionally known as pain generators, but if they're very large, if they're applying pressure in certain places, they can be. So within the pelvis, there's so many players, and you need to think about all of them when you are an endometriosis surgeon, because if you only think about endo and you only do surgery for endo, you will fail and the patient will be unhappy. They will be back in your office, or they may go to another gynecologist and hope for a different outcome. So I think we really need to be changing the perspective around endo to not just focus on endo, but look at endo as one of the players.
One of the players in a cranky pelvis, which is what I like to call it. And one of the old-fashioned criticisms of a surgeon, or even not as a surgeon, any kind of specialist practitioner, is that if you're a hammer, everything's a nail. So if you're an endometriosis excision surgeon like yourself, I'm sure that it can be tempting to really want to focus in on those individual lesions and actually miss some of the other players that are going on there. And we've talked about, and we will continue to talk about things like the bowel and the pelvic floor and all of the other things that are going on in a busy, cranky pelvis. Which I have taken us on a very big tangent, which we weren't planning on, but such a good one. I wanted to come back and talk a bit more about cysts, because again, for both patients and practitioners, and I'm thinking as myself as a GP, can be a huge source of stress and concern, because the last thing anyone wants to find if they have an ultrasound is have someone, radiologist plus or minus GP, worried about a cyst, like a complex cyst, and what that means. Because of course, the first thing is that, everybody's worried about is this going to be a cancer? Mm. And if you're talking about an endometrioma, which is a benign kind of pocket of endometriosis sitting inside the ovary, being described as a complex cyst, I can assure you that the patient's first thought is going to be, oh my God, is this cervical cancer? It's not cervical cancer, ovarian cancer. So if we talk about a simple cyst, that might be that fluid-filled bubble. Sometimes they talk about septations, or there's these internal walls in a cyst. What's that about? What's happening there?
We have sonographic descriptors that help us characterize what we see. So we can talk about a cystic lesion as a unilocular, which is one pocket of fluid, or bilocular, two pockets of fluid, or multilocular, and that can be as many pockets of fluid.
So one bubble compared to like a bunch of bubbles that you might have in the washing up liquid sort of thing, or in the bath, in the bubble bath.
Correct. And they're connected to each other. And so we have the terminology around the locularity of a cystic lesion. And when something is multilocular, that's where the term septation comes into play, although we've moved a little bit away from septations in a sense that it's redundant. When you say something is multilocular, by definition, there are septations. We talk about solid components to cystic lesions and papillary projections, which is a specific type of solid component that comes from the wall of the cyst rather than from a septation. We talk about the vascularity pattern. So with ultrasound, we apply Doppler, and that shows us how vascular a structure is. And we have ways of characterizing the vascular pattern from score 1 to score 4. And of course, with cancer, we see more vascularity. So when it's a score 4, that's when the flags start to go off for us. And so we use these terms to then help us know from pattern recognition, what is it? So an endometrioma is a unilocular cystic lesion with ground glass echogenic findings within. That's the content of it.
So it might look sort of grainy sort of thing on a...
Exactly, grainy. They're usually quite smooth-walled without any solid components or papillary projections, and they usually don't have any abnormal vascularity.
Yeah, so there's blood in there, but it's like old blood, like you've had a blood nose or whatever. It's sitting there, but it's not sitting in vessels that's
Correct.
Actually pumping around that the lesion itself is sort of generated, I guess.
Correct.
Yeah, okay.
And so when we see those patterns, that's how I know it's an endometrioma. So I don't say complex cyst. That's a bad word amongst those of us who are sort of at the leading edge of gynecologic ultrasound. Should never be used. If you see on your reports complex cyst, maybe you've gone to a clinic that's still a bit dated, sorry to say.
But I think that's really important, isn't it? It's not
yeah.
sorry to say. It's like, should these patients be going to, or it's important to get the patients to the right clinic, to get the right investigations, to give them the right information.
I agree. And I think in our health systems, it's not always so clear where a clinic or
Correct.
clinician is at in terms of their knowledge. And I see what's happening in Canada, and I think it happens here as well with respect to ultrasound clinics, is you just sort of assume that everybody's quite the same and they're following standards. And in some ways they are following standards, but when there is evolution in a concept, there's somebody at the leading edge, and that's not always at the standard of care. It's a bit further beyond.
Yeah, that's right. Yeah, medicine changes rapidly, doesn't it? And sort of thinking if you're someone with pelvic pain or endometriosis and you're having an ultrasound done and then reported by someone who is then going on to do a shoulder and then a knee and then takes a foreign body out of someone's elbow or whatever it is, it's going to be quite a different approach to someone like yourself and someone like Ali that we interviewed recently. It's completely different kettle of fish, and the information you get back is quite different. But you're right, it's not always that easy to know out there. And I would say in Australia the quality of pelvic ultrasounds are improving rapidly, including people like Ali who are actually helping to train sonographers how to do this better. But the other thing that I keep thinking about when you were mentioning around what the report says is that now in Australia we have ability for patients to see their own results before they may have seen their doctor. So we have a program called My Health Record, which in many ways has been quite useful in terms of sharing information. But you can imagine someone looking at their report and be like, oh, there's a complex cyst. You go and Google it, we go and pop it into ChatGPT, and their worst case scenario before they've even seen you, which certainly may lead to some, maybe not ending up sitting in front of the right person. Before we move on, I really want to talk about, before we move on, I want to talk about, because you mentioned the teratoma, and I thought, I think we should mention this before we move on. Yeah, this isn't in our prepared question, sorry. Is a teratoma is terato in Latin, Cherie, means?
I don't know Latin. Why are you asking me about Latin?
It means.
You have the French name.
Yes, you must know about Latin.
You must know Latin.
My brain went straight there. Tell me.
Monster.
Monster.
Terato means monster. So an oma means tumour. So it's a monster tumour, and it's made from the sort of different kind of almost stem cells. That's how I think about it. So you can have a lesion on an ovary, which is a cyst or a lesion. You can explain this to in a minute, but it can grow teeth, it can grow hair, it can grow eyes.
I've seen that on a Grey's Anatomy episode.
Okay.
No, I don't
Am
think
I
eyes.
just making up eyes? Because I was thinking
Scalp.
it was scalp. Yeah, and I've I've probably seen them in textbooks, but I've actually never seen one. But yes, other than me mashing up that story, can you tell us a bit about a teratoma? Because that is something important to know about, and they can get quite big, can't they?
Yeah, for sure. I mean, you explained it well. It's a cystic lesion. It's benign in the vast majority of cases, mature teratomas that are from stem cell origins. So they can grow anything like hair. They can grow digestive tissue, brain tissue. So there are some more weird and wonderful ones, but they're pretty gross. Hair is common, and these also have very classic appearances on ultrasound. So unlike what's happening in a lot of places where they're describing complex cysts, when we see the features of a dermoid or a teratoma, we say this is aligned with a dermoid. So we say what it is. So then people don't freak out over the term complex cyst.
Yes, absolutely, because that's terrifying.
Yeah.
So what I'm hearing is let's get rid of the term complex cyst.
Complex cyst.
My goodness, yes.
Yeah.
It needs to go away.
That's a T-shirt.
We were talking to Ali about what needs to go on a mug or a T-shirt.
Yep.
So get rid of complex cyst.
Yes.
Perhaps with just a picture of a teratoma.
Maybe.
Teratoma version
You
of you
always
and
take
me.
it to the next level.
I'm sure we can get ChatGPT to come up with something like that.
But yes,
for it.
let's get rid of complex cyst.
Complex cyst, okay, yeah, absolutely. That's important because that is a really quick way to terrify someone.
Mm-hmm. And you don't want to terrify, anybody, but you especially don't want to terrify somebody who has pain system hypersensitivity.
Absolutely.
Oh, wow.
Because the brain goes to danger zone, red flags, and then everything is felt even more.
Yeah.
So really, endo is a terrible disease, but it is benign. And that's really important for people to know. I am safe. And, there are some rare instances where organs can be compromised, kidneys, of course, and bowel, but 99% of people, they are safe. They're not going to die. Nothing dangerous is imminently going to happen to them. And so acknowledging the severity of the disease, how impactful it is in their life, but at the same time, reminding people you are safe is so key. And so using language that is going to give you a clear answer is important in helping people know that they're safe.
Absolutely. And we talk a little bit, it's probably not the best term, but the psychologists talk about catastrophizing. And I think anyone who's been in a chronic, complex pain, persistent pain situation will know what that means, in that if something comes up, it's very easy to go to the worst case scenario because you've probably been through a lot as it is. And you're like, I can't cope with this. What if I'm back? What if I'm going to this place? What if I have to have this? And you're right. That is a really good way to really dial up that whole pain system, amplify the pain system. And that's, absolutely. So in terms of actually being mindful about what our words mean, because you're right, words are really important.
And people can't see inside their bodies. So when you have a sensation and you have a pain system that's already hypersensitive, you go to the worst place. So I talk about trying to paint a true narrative for patients with ultrasound and also with the clinical history and physical exam and putting it all together, but painting a true narrative to what is happening in your pelvis right now. How can you start to understand that and shift the narrative from what you think is happening to what is truly happening? And his example would be lots of patients with endometriosis have symptoms that are gastrointestinal. They have pain with bowel movements. And they think, I must have bowel endometriosis, or I must have endometriosis that's just enveloping my bowel and nothing can pass. And actually, you don't have to have bowel endometriosis to have GI symptoms. And so when I try and tell people your GI symptoms are real and likely they are connected, related to endometriosis, but your bowel is not being strangulated, that is helping them understand what is happening and what is not happening. And I think that's really key because we cannot see inside of our bodies. And we have to help people know what's happening when they are in this state of concern, curiosity, fear, uncertainty.
And sorry.
I was going to say, on what you just said, I feel like you really encapsulated that on your social media page, which I stalked beforehand. Do you remember that quote?
The body, but reading the body.
Yeah.
Can you?
I do have it.
You have it?
You said, when you can read your body, you can change its story. And I thought that was really beautifully said and a powerful sentence.
Yeah, it's really true. And in the space of endometriosis, again, it's not just endometriosis. There's a lot of stuff going on. And so you really need to understand sort of the full scope of what is happening in your body as it pertains to endometriosis, as it pertains to other comorbidities. And that can be gynecologic issues like PCOS or adenomyosis. It could be GI issues. It could be that you have a history of trauma. And a lot of patients with endometriosis do have a history of trauma. A lot of women have a history of trauma. And so understanding that full scope is really key, and putting it all together to then decide, what am I doing next? How am I going to target the issues that are present, and do that in a really nuanced way? You can absolutely change your story with endometriosis. It takes a lot of work.
Yeah, it does.
Sadly.
It does, but it's possible, and there is hope. And one of the things that we talk a lot about when we run groups and when I meet with patients is the concept of sense making. And that's what so many AFAB folk and women who come in to see me, they're really just trying to understand what's going on, and they're trying to understand something that they can't see, as you say, that's really complex, which there is, so much misinformation and so much information which leads them to kind of sometimes blame or target, the wrong thing. And yeah, I mean, how great for someone like yourself to be able to sit with them. Mm-hmm. And we were talking with Ali about, if you're doing an ultrasound on someone, you're really sitting there with them for some time. Ali likened it to a psychiatrist kind of couch, it's like she called it confessional,
a vulnerable confessional.
Yeah, that's right. So I mean that's so powerful therapeutically, I imagine for you as well.
That's why I say diagnosis is therapy.
I know. Yeah, lovely. Tell us about that. Yeah,
it's the knowledge of what's happening is so valuable and therapeutic to people. I have people coming to me as a surgeon who are completely disinterested in any kind of surgery. They have learned that you can evaluate for endometriosis in a non-invasive way now, and they just want to know what is happening. And they have often figured out a lot of solutions, self-management strategies to live their life, but they need to know. And then they sort of close a chapter and they say,
absolutely,
I know what's happening now. I don't want any hormonal medications. I don't want any surgery. They might be doing physiotherapy. They might be working on a diet strategy. They have heat packs. They do meditation, whatever it may be. For an individual, they come up with their combo. They just need to know.
Absolutely. I see that all the time. And I mean, a patient that I've seen who stands out really strongly to me was well into her 70s when I met her in our persistent pelvic pain clinic, and had been struggling with pelvic pain for decades, and literally came to see me with an armful of folders, which were really neatly organised into different procedure, different event, different decade, different specialist, and had been spending so much time and effort just poring over these documents, trying to make sense of it. And we spent an hour together going through similar kind of conversations that we're having today, talking about the way that pain can dial up and down, the way the pelvic floor gets involved, the way the bowel gets involved, and was able to leave that appointment really without me doing anything else to be able to sort of pop that part of her life down to a degree and start moving forward. And that's just incredible.
I scan a lot of patients for different things, postmenopausal bleeding, for example, or variances into the postmenopausal years. And if we see endometriosis or adenomyosis, we actually still describe it. In some cases, it actually may still be clinically relevant when it comes to endometriomas and cancer risk. But I describe it because often these people suffered for their reproductive years while they were menstruating, and they never knew why they were suffering. And so if you can provide somebody who's 60 with an adenomyotic uterus an understanding that that might have been why they had terrible dysmenorrhea and heavy menstrual bleeding.
So that's painful, heavy yes. bleeding. Yeah.
If they had these, now they have an answer. And that can provide a little bit of closure for them as well. So I describe it even into the postmenopausal patients because they deserve to know.
You're out there changing lives, not just in the operating theatre.
He's now like elevated to some sort of Disney Superman prince. But the right information is key to make informed decisions. But also what I hear is then the way forward is very individual, isn't it? I think that's the other message is that we can get so caught up in information that maybe not relevant or can get you stuck with some misinformation that's out there. So actually coming back to who are your practitioners? Are you getting the right information, the right investigations in the right way so that then you can make an informed decision on your own health and well-being based on what is happening with your body's story.
It does make it harder for it to be such an individualized approach, because everybody in medicine would just love an algorithm.
Yeah.
You know, there's a terminology we often use in medicine: first line, second line, third line. This does not apply in endometriosis. And I think that we've seen guidelines shift. I know that the updated Canadian guideline that's close to being published has kind of done away with the terminology first line, second line, and really shifted to an individualized approach. You know, you may walk into your GP's office or your gynecologist's office and never having been on anything, and you may be appropriate for surgery, right? Versus trying a hormonal treatment for 6 months first. It should be that individualized approach, and using all that information, putting it all together, and then giving it to the patient to say, what do you think is the right option for you?
Amazing. Just coming back to the endometrioma, one of the things I've heard you say on your socials and in podcasts is around, and you mentioned it earlier, it's the tip of the iceberg. So, and you have been quite clear on your thoughts around, if an endometrioma is found at ultrasound, there needs to be some really clear evaluation done before any surgery to save you getting caught out as a surgeon and a patient, I guess. Can you talk us through what that means to you when you see an endometrioma, you know, perhaps in a report that's come from somewhere else?
Based on published literature, there is a really high association between endometriomas and deep endometriosis. Probably about 2/3, maybe even 70% of those with an endometrioma have deep endometriosis, which is the infiltrative type of endometriosis into the peritoneum, often the uterosacral ligaments, could be into the bowel. And this is very difficult to see surgically. This is the type of endometriosis that's much easier to see sonographically because we can see through tissue. Again, surgeons, as I said at the beginning, we can't see through the opaque tissues of the pelvis. And often when there's severe adhesions, the deep endometriosis is under the adhesions. So you also can't see through that tissue either. So knowing that there's an endometrioma, you should have almost a default assumption that there is deep endometriosis. And so I've seen, there's a little bit of shift away from this, at least within a Canadian landscape, that, you know, if you have this cyst, an endometrioma, you would go for a laparoscopic cystectomy, the removal of a cyst. This does not make any sense in my mind. It should be a laparoscopic excision of endometriosis, including a cystectomy, if a person pursues a surgery, because there's going to be more than just the cyst. And so this focus in on the cyst as the culprit of all of the problems is so narrow-minded, and the focus in on the cystectomy as the solution is also just wrong. And so for a person with pelvic pain and endometrioma, you should never be pursuing an ovarian cystectomy as a sole procedure. And if the gynecologists say, I'm just going to go in and take out this cyst, and, you know, not acknowledging the rest of the potential disease, red flag, maybe get a second opinion on that, because they're just not really thinking about this disease correctly.
So how does it work in terms of if you're seeing someone with an endometrioma, and obviously you have very, very adept skills sonographically, like looking at ultrasound, how do you actually map what's going on in someone's pelvis before you go into surgery, or do you sometimes do it during surgery if it's hard to see with the direct eye, but you can see it with the ultrasound?
Scans should always happen preoperatively in the office with the patient awake, because people need to learn about what's happening in their pelvis in order to make informed consent about what is done in their pelvis at the time of surgery. I have a saying, it'll come up in my lecture tomorrow at Ranscog. Patients should not be surprised as to what happens when they wake up from surgery. Patients should, as much as the surgeon, have the roadmap. What is the surgeon going to do? Of course, there is always a potential for some surprises. You know, imaging is great, but it's not perfect. And so we do still often tell people, you know, if we see something on the appendix, which we might not know about beforehand, you know, can we take out your appendix? We ask for consent to do that. But when it comes to deep endometriosis, it's actually quite easy to see if you know how to perform the scan through a very standardized process to evaluate the posterior compartment, which is everything kind of behind the uterus, the bowel, the vagina, the peritoneum, the uterosacral ligaments live there. And then we evaluate the anterior compartment, which is everything in front of the uterus. That's the bladder primarily. And then the ureters, which connect the kidneys to the bladder. And so when you evaluate everything in a really standardized approach, you get the map in the office and talk to the patient about the map. And then this is what we're going to do. we actually do bring a machine with us to the operating room, to theater, because it's a great learning tool for our residents and for our fellows to see it really so close in proximity to the surgery. So we scan the patient after they've been put to sleep, then we operate and people get the back-to-back image. Great educational tool, but also great for us to just get that map again visually. Because when we have our report, we know what we mean, but it's not always the same as seeing it.
Absolutely. That's amazing.
You describe, we've been talking about pain-generating events, and surgery is often seen as the fix, but you describe it as a pain-generating event. So can you talk us through that? Yeah,
it is. Surgery is, a process by which we are literally cutting into your body and cutting structures within your pelvis. And it's a massive inflammatory event. And so research that's come out of University of British Columbia allows us to understand who may be a good surgical candidate or not. It's a quite simplistic breakdown using the central sensitization inventory score, which, like the catastrophization in the community, doesn't always have the greatest reputation because of the reliance on, this is just in your brain. You're making it up. It's not, not real endo kind of thing. But they are really useful tools that can be helpful. And so the UBC group showed that patients who have a CSI score of over 40 have worse surgical outcomes. So their pain system is more hypersensitized than a person who scores 30 or 25 or something like that. So if you have that high score, it doesn't mean you're not a good surgical candidate all in, but you probably will not do as well as somebody with a lower score. And that event may be more stimulating to that nervous system as well.
So if your pain system's already dialed up, surgery is, may well dial it up even more.
Absolutely. And our anesthesia colleagues, they know this as well. Their reliance on medications in the post-operative bay is different for a person with chronic pain who is used to using pain medications regularly than somebody who's not using pain medications regularly.
What would you say to someone who potentially obviously has been on a journey and just wants the surgery and is like, I have endometriosis and I want surgery?
I would say that unfortunately, it's a really hopeful and simplistic desire. I wish that would help. As a surgeon, it would be fantastic if that's all I had to do was go in and cut it out and people were better and patients would be back off to work. But it's just not the reality for the majority of people. And the simplistic mindset of, I just want the surgery, I want everything out. And on our intake form for our clinic, I ask people, what are your goals? And sometimes people literally write, I just want everything out.
And you can understand why they want. I totally understand it.
I get it.
Yeah, it's like, cut enough. Just this has got to be the answer. I need this to be the answer.
Exactly. And so it's really tough to be in the position of having to kind of reel people back a bit and say, it'd be really nice if we could just cut it all out and you'd be better and, your quality of life would be 100% again. Endometriosis has done a lot of damage to people, to their nervous system, to their GI system, to their muscles. And that doesn't change overnight or post-operatively. It requires a lot more than just a surgery. And so it's our job to do that. And for the surgeons out there who are probably not listening to this,
maybe
I hope they do. I really would hope that they'll shift their focus to just repeatedly operating on people, to really looking at the human and trying to help them holistically, because repeated surgeries are not the answer for people in the majority of cases.
I think that's so important to hear coming from someone like yourself, who is a specialist excision surgeon. And, out there, if you listen to people who haven't had the benefit of some of these conversations, someone who's been around the traps with endometriosis for a while, perhaps has had some surgery, they'll say, you need to go and find the specialist excision surgeon, because excision surgery is the gold standard treatment for endometriosis. But I've heard you make some comments, I guess, to perhaps broaden that discussion a little bit.
I definitely think people need to find an endometriosis-focused surgeon to be able to get the full scope of options and the full scope of counseling. if you're seeing a surgeon who cannot do endometriosis surgery because their skill set doesn't permit it. And in Australia, there are very clear RANSCOG levels of surgery. And so if you're seeing somebody who's level 2 or 3, they cannot offer you excision surgery or even more advanced gynecologic surgery. So therefore, you're really not getting the full scope of your options in that consultation. So you do need to find people who have the knowledge of that type of surgery, but also endometriosis beyond surgery. Because again, it's not just a cut out the lesions type of disease. And I think that's really key for the success of patients with endometriosis is they have that specialty care. We do need to train up our general OBGYNs and of course our primary care providers as well to be able to do a lot of the management before they get to the endometriosis surgeon because wait times are excessive and there's not that many of us. So it does need to be a team approach. But I do think an endometriosis surgeon is key. And the gold standard terminology, that needs to go away. This is just garbage. The gold standard diagnostic, the gold standard treatment, there is no gold standard. And I really urge people.
It here.
That's a mug.
That's a mug.
I urge people in the social media space to, when they hear somebody say this is gold standard, to say this is too simple. These are catchphrases on Instagram or TikTok. If somebody says this, they are just it's clickbait. It's trying to get people to listen to some message that's ultra simplified when this disease is much more complicated than there's just one gold standard and that's all you need and you're going to be golden after you get this gold standard treatment. It's garbage. Sorry.
I love that, which is an absolutely great segue to hear a little bit about what you're doing in the Endometriosis 360 clinic in Canada. And I've certainly heard you say before that endo can't be treated with a single intervention approach. Tell us what you're up to over there because it sounds really, really cool.
I think it is. Endometriosis 360 is a true interdisciplinary program. So interdisciplinary means that we are mixing different disciplines in one space.
Ew.
Who does that?
No, we love mixing between.
Exactly.
So much gold. That's where the gold is.
Yes. Because you see things differently, you see things similarly, and you can work on a person who's three-dimensional in a way that's much more nuanced. So interdisciplinary is different than multidisciplinary, where you might see a physiotherapist in one space on one day, and then you might see a psychologist, and then you might see your endometriosis surgeon on a different day. Interdisciplinary is when you see everybody all together. So our program is consisting of a registered dietitian, Emily, pelvic floor physiotherapist, Jill, and a pain psychologist, Laura. And they do an interdisciplinary assessment of our patients. And then
together, all three
together.
of them
In the one room.
In the one room. It's a virtual program, which makes it very easy. And
so good.
Also, Canada's huge. Like Australia, we have lots of rural patients who just cannot get to a place. So it's all virtual. And essentially, those three individuals who are really nuanced in their understanding of endometriosis as it pertains to each of their domains, they will do an assessment of the patient and then provide guidance to that patient at the conclusion of the visit. Depending on the patient's stage of change, willingness, their insight into their pain system, their other mental health conditions or other issues in their bodies, they may be eligible for the group program, which is a 6-week program, 2 hours per week as it stands now, although it's still relatively new. We've just finished running the third group, so subject to modifications and change with time, but essentially 2 hours per week. And really the foundation is pain science, is understanding what is happening to your body, what is happening in your nervous system as it pertains to your GI system, your myofascial system, your muscles, and then the psychology of it all in the context of endometriosis. So everybody in the program has a diagnosis of endometriosis, and generally speaking, they have as well a persistent pain state. And the goal is to provide them with solutions that are not just medications and surgery, but a true interdisciplinary approach.
I love the talk about interdisciplinary or intradisciplinary. I've heard multidisciplinary, which is, I guess, where this idea started. It's a bit like having the little kid who doesn't like their food touching on the plate. So there might be some broccoli here and the chicken here and the carrots over there. Whereas interdisciplinary is where it's more like a soup. So everything is sort of mixed together. There's a lot of discussion between patients and between the practitioners. There's a lot of work together, which is similar to what you're doing at Endometriosis 360 in our clinic, is the same thing. And you and I, Cherie, we're deep in the soup. We don't even know how to find our way out back again in this.
It's that we like to call it collaborative care.
Or soup.
It's collaborative soup, yes. Where I don't even know how to weave into this, but I think it's important that everyone is talking together as well as the patient as well, because sometimes I think, well, in situations I've heard where there's so many people involved, and almost sometimes the patient gets even forgotten by the wayside.
Oh, definitely. We talk a lot about fragmentation. Which is just horrible for everybody, especially the poor person who's going through the endo or the pelvic pain.
Well, we've had patients who have come to us in our gynecology clinic at McMaster, and we do our advanced ultrasound, and we say, you have endometriosis, but your bowel's not involved. You have a lot of GI symptoms, so let's get you to work with a GI specialist as well. And then the GI specialist will say, oh, you probably have bowel endometriosis, which we have just ruled out.
Yeah.
And so they're getting mixed messages. And so that's maybe multidisciplinary, where there's a disconnect and then mixed messaging happens.
Yeah.
If everybody's in the room at the same time, you can't get that. So we have to aspire to this interdisciplinary model.
Yeah.
And I just want to tell the Aussies who are listening, you guys are very lucky. I know that in endometriosis care everywhere around the world, it's still broken and deficient.
Yes.
And, things are being too slow. We're not moving fast enough. But I don't think there's any country in the world who has established pelvic pain and endometriosis clinics situated around the country, supported by the government. We do not have this in Canada. So there is a lot of evolution, and Australia is absolutely the leading country in the world, in my mind, when it comes to endometriosis care and research.
It's definitely coming along, although, medicine takes a long time to change. So, but the way that that our federal government has invested in us and the other clinics has allowed some real leadership around this, which has made a huge difference to the people that we look after. And we just keep sucking people into the soup, really, because our bowel person that we involve works with us and knows us and understands. So we don't get those, or as often we don't get those difficult times where you get this, sort of tap back, with the ping pong ball. It just doesn't need to. And once you can pick up the phone and text or email or chat to your colleague, depending on whether they're an exercise physiologist, a physio, a gynecologist, or a colorectal surgeon, whoever it is, just so much time is saved, so many resources are saved. It's such a better way to do things than the traditional.
Yeah. So I think in the meantime, I think it's good, again, for podcasts like this and information where people can have that understanding that if that does happen to them, that they're informed, so they can go and get a second opinion or question what's being said to you.
Is this the best thing for me?
Sometimes we do have to be our own advocates sometimes, unfortunately.
Absolutely. Yes. But that brings me back to the sort of single intervention approach. So I'm sure that when the Endo 360 clinic is meeting with someone, very unlikely that they're going to get a treatment plan with one thing on it. Or perhaps it's one thing at a time. What might a treatment plan look like? I mean, I know that everyone's would be different, but...
When it comes to endometriosis 360, so the three domains, again, are psychology, registered dietitian, and physiotherapy. So you can sort of break it down a little bit by system. Within the psychology space, it's really a lot about understanding your nervous system. So there's elements of mindfulness, there's elements of CBT, cognitive behavioral therapy. Within the domain of registered dietitian, this is really individualized. So I know in the endo space, lots of people talk about an anti-inflammatory diet or a low FODMAP diet. That doesn't work for everyone. So Emily takes an individualized approach and then provides guidance as to what are the triggers, what are supplements that are missing, and understands sort of behaviored eating as well. And then physio, you can do a lot of stuff virtually, a lot of stuff from home, but that also may involve going to a physiotherapist in real life and having manual therapies with them. But that's heavily focused on breathing and stretching type exercises. I'm really simplifying it. So, because I'm not any of those people. And if somebody tried to explain what I do, it'd probably be a very simplified approach as well. But that would be the sort of breakdown.
We talk a lot about the and. So it's never just one thing. It's it's the and, isn't it? It's never the or. So it's, how are you moving? How are you breathing? How much support have you got? What are we thinking about bowels? What are we thinking about your pelvic floor? It's the combination of those things that make a difference rather than just one thing. So if you're trying one thing, it might be that not that it doesn't work, it's just that we need to look at what else is happening in the picture at the same time, in the whole picture.
And that changes over somebody's life.
Of course.
When somebody's 16, they're not the same as when they're 25 or 39 or 48. So endometriosis is a lifelong disease for most, right? And we can't apply the same treatment to somebody who's in an adolescent age range to somebody who's trying for pregnancy actively or somebody who's perimenopausal. We have to evolve with them. And so the guidance and the advice will change with time. And, you know, we haven't seen this in a way that, for example, in diabetes clinics, people know that this is a lifelong condition and you have to manage it and keep an eye on things. Endometriosis still requires this. And I think, again, here in Australia, with the pelvic pain and endometriosis clinics, you have the best chance right now of providing that longevity and being with people long term. So I'm really enthusiastic about this model because I think combining that with the advanced gynecologist and the advanced imaging and the interdisciplinary approach, it's going to result in the most likely successful quality of life. It's never going to be perfect. The expectations are important, right? If you have this illness, the sad reality is, you know, you have this illness and we're probably never going to get you to be completely pain-free or symptom-free, but we have to figure out how do we manage this illness in a way that allows you to succeed in your career, in your family life, you know, as much as you want. That's, for me, the goal is helping people live with endometriosis.
Oh, fangirling so much. Traditionally, you know, we don't think about surgeons having such a broad, holistic approach, really, and it's so lovely to see that changing. We interviewed Dr. Krista Gillespie, a colorectal surgeon, pelvic floor surgeon, recently, same thing, and it's just so refreshing to hear that. And it has to be that way. It has to be that way, doesn't it? But it's just still, it warms my heart. Matthew, we're just about out of time. If you had to leave us with one or two, you know, take-home messages from today about, you know, how to think about their care, including what might happen if they have a complex cyst on their report.
Well, we're getting rid of that, but anyway,
like if that's what they get in their report. I mean, we're not quite clever enough to move everybody along.
Not everyone's listening to us.
Any sort of final thoughts for us?
Absolutely. With endometriosis, don't think of it so simply. It's much more complicated than just lesions. But knowing about the lesions in as detailed a way as possible through advanced imaging is key. So knowing about the lesions, where they are, the endometrioma, the deep endometriosis, the superficial endometriosis, the adhesions, knowing about the concurrent pathologies like adenomyosis, PCOS, fibroids, knowing about that in as much detail as possible will provide you with a true narrative as to what is happening and what is not happening, which allows you to kind of exist in a state of stability, calmness within your nervous system. Having that holistic approach is really key, but it's foundationally based upon knowledge of what is happening through advanced imaging. So if you're getting evaluated with scans that are the basic scan where only the uterus and the ovaries are being reported, that's not enough. We need more information than that. If you're being told surgery is the gold standard, that's not enough. You really need more information and more options, more of a interdisciplinary approach than just really simplified. I think we're getting to that point with endometriosis to know that it's not so simple, the diagnostic approach, the treatment approach. But if you're getting that simple approach, you probably won't be satisfied.
Dr. Matthew Leonardi, and it has been a joy and a pleasure. Thank you so much for your time, taking time out of your busy schedule. I hope you enjoy Adelaide. I hope you get to see a koala like we pointed out where one is. And we hope we get to adopt you and have you spending a little bit more time here in Australia moving forward.
I would love to come as often as possible. I love Australia and the work that is happening in endometriosis. It's really optimistic and it's changed my life for sure, being in Sydney for many years and coming back regularly. I did see black cockatoos in Adelaide just yesterday, which was a huge pleasure. I will go on the hunt for the koala. I won't hunt it.
That is not allowed.
No, I will just look at it.
Thank you so much.